Anticoagulants explained. Heparin, Warfarin, and the DOACs. Blood clots save lives. They stop us from bleeding to death after an injury. But when clots form in the wrong place, inside a coronary artery, a cerebral vein, a deep leg vein, they become killers. Anticoagulants are the drugs that prevent and treat these pathological clots, and understanding how each one works is essential for anyone in clinical medicine. Welcome to Medical Sciences Unfolded. Today we cover the three major classes of anticoagulants: heparin, warfarin, and the DOACs, the direct oral anticoagulants. Let's begin with heparin, the oldest and most widely used parenteral anticoagulant. Heparin does not directly inhibit clotting factors itself. Instead, it works by binding to antithrombin 3, a naturally occurring serine protease inhibitor circulating in the blood. This binding causes a conformational change in antithrombin 3 that dramatically accelerates its ability to inhibit thrombin, factor 2A, and factor XA by 1,000-fold. The heparin antithrombin complex essentially turbocharges the body's own anticoagulant mechanism. Unfractionated heparin, or UHF, is given intravenously or subcutaneously and requires monitoring with the activated partial thromboplastin time, or APTT, targeting 1.5 to 2.5 times normal. It has a short half-life and is reversible with protamine sulfate, critical for surgical patients. Low molecular weight heparins, such as enoxaparin and deltaparin, are derived from UHF by chemical or enzymatic cleavage into shorter chains. They preferentially inhibit factor XA over thrombin. Their advantages are predictable pharmacokinetics, subcutaneous dosing, no routine monitoring required, and lower risk of heparin-induced thrombocytopenia, or HIT. They are renally cleared, so dose reduction is needed in kidney disease. Heparin-induced thrombocytopenia, or HIT, is a critical and counterintuitive complication. The body generates IgG antibodies against the heparin PF4 complex on platelet surfaces. These antibodies activate platelets paradoxically, causing thrombosis, not just thrombocytopenia. The classic 4T scoring system helps identify HIT. When HIT is suspected, heparin must be stopped immediately and replaced with a non-heparin anticoagulant such as argatroban or fondaparinux.
Now warfarin, the oral anticoagulant that dominated clinical practice for 60 years. Warfarin inhibits vitamin K epoxide reductase, the enzyme that recycles vitamin K into its active form. Vitamin K is essential for the gamma carboxylation of clotting factors 2, 7, 9, and 10, as well as the anticoagulant proteins C and S. Without functional vitamin K, these factors cannot be activated. Remember them with the mnemonic 1972, factors 2, 7, 9, X, and proteins C and S. Warfarin has a narrow therapeutic index and enormous interpatient variability in dose requirements due to genetic polymorphisms in CYP2C9, which metabolizes warfarin, and VKORC1, the gene encoding its target enzyme. Monitoring uses the INR, targeting 2.0 to 3.0 for most indications or 2.5 to 3.5 for mechanical heart valves. Warfarin interacts with hundreds of drugs and foods, particularly vitamin K-rich foods like leafy greens, which blunt its effect, and drugs that inhibit or induce CYP2C9. Reversal uses vitamin K, fresh frozen plasma, or 4-factor PCC for urgent reversal. The DOACs, direct oral anticoagulants, have largely replaced warfarin for non-valvular atrial fibrillation and VTE due to their predictable dosing, no routine monitoring, fewer drug interactions, and superior safety profiles. There are two classes. Direct thrombin inhibitors, dabigatran, brand name Pradaxa, directly inhibits thrombin and is the only oral DOAC reversed by idarucizumab. Direct factor XA inhibitors, Rivaroxaban, Xarelto, Apixaban, Eliquis, and Apixaban, Savesa, all directly inhibit factor XA. Andexanet alfa reverses factor XA inhibitors. The key DOAC advantage over warfarin in the REYLY, Rocket-AF, and Aristotle trials, DOACs showed equivalent or superior stroke prevention with significantly lower rates of intracranial hemorrhage. Apixaban in particular showed the best bleeding safety profile. Contraindications for DOACs: severe renal failure, since most are renally cleared, mechanical heart valves, where warfarin remains mandatory, and antiphospholipid syndrome, where warfarin outperforms DOACs. Clinical Pearl: when switching from heparin to warfarin, always overlap for at least 5 days and until INR is therapeutic for 2 consecutive days, because warfarin initially depletes protein C and S before it depletes the clotting factors, creating a transient procoagulant state. Thank you for watching Medical Sciences Unfolded.